Good morning and welcome to the first instalment of Podiatry in 3 Minutes, a live webinar where we challenge a researcher to explain their most recent podiatry-related publication within just 3 minutes.
Today, myself and Jenny will be your presenters. My name is Sinéad Flynn and I'm a new graduate of Paediatric Medicine from NUI Galway. I was this year's Tomorrow's Podiatry Student of the Year and I'm currently undertaking a Research Masters in NUI Galway.
And I'm Jennifer Andrews. I graduated from the University of Salford in 2019 with a degree in podiatry, and I am now a PhD student within the EPSRC funded Centre for Doctoral Training in Prosthetics and Orthotics, and my area of study is the soft tissue characteristics of the foot.
And of course, in the background we have Michael Stevenson, the brains behind the webinar, pushing all the right buttons and ensuring everything runs smoothly.
First of all today, as this is our first episode, we'd like to run through the structure of the webinar in greater detail. So each episode will have 2 guests, the first of which is a researcher who will be explaining their paper within 3 minutes, and the second is a researcher or clinician who works within the same field.
After the 3 minutes are up, the 2 guests will discuss how the published work exists within our surrounding body of evidence, and how we may be able to apply their work to our clinical practice. Following this, we will open up the floor to questions from the public. So I think it's time to introduce today's guests, Cylie Williams and Nina Davies.
Good morning. Associate Professor Cylie Williams is a podiatrist and a researcher. She is the Allied Health Research Lead at Peninsula Health and a Senior Research Fellow at Monash University. She also currently works in private practice with children and their families with complex health needs. She currently is the leading international researcher about idiopathic toe walking and has collaborated with toe walking researchers in the UK, USA and Spain. Good morning, Cylie.
Good morning.
And of course, Nina Davies is a podiatrist working in Leeds Community Healthcare at Staffordshire University. She's a visiting lecturer in paediatrics as part of the Clinical Biomechanics MSc Award. Her clinical caseload has focused on MSK conditions and paediatrics, and she is currently leading a project developing a citywide course on the management of long-term conditions.
Welcome.
How are you feeling, Cylie? Are you ready to do your 3 minutes?
Let's go. The paper I'm talking about today is the American Australian experiences while receiving diagnosis or having treatment for idiopathic toe walking. It's a qualitative study. In this paper, the object of this paper was actually to describe and have parents tell us their stories. The main aim was to understand parents' journeys while navigating diagnosis, but also navigating treatment and assessment of their child who had idiopathic toe walking. Idiopathic toe walking is when a child walks up on their tiptoes and has no medical conditions. We chose the setting for this study as across 2 very different health services and health service settings. So America, primarily a private or insurance-based health service, and Australia, who had both public and private health that children could access. We used a mixed method qualitative study where we used a survey, but we also used structured interviews by parents. We invited parents who had seen more than one health professional during their journey with their child, so we could understand what some of the challenges that they'd had during this time. When we say we asked them questions, we actually interviewed the parents for about an hour, and sometimes mums and dads, and sometimes mums, dads and their children participated, and they talked generally to us for about an hour. We also asked them to answer a survey called the Measured Processes of Objective the measures of processes of care, or the MPOC 20, and it gives us an idea around what the complexities of care are, and we use that to help us guide the analysis. We recruited 10 children, and I know that sounds like a small number, but they gave us very, very rich and detailed information, and surprisingly very similar information despite the diversity of the healthcare settings that they accessed over this time. The children were aged between 3 and 13 and had often quite similar journeys, with diverse health professionals recommending diverse treatments, with sometimes a challenge in when and where and how they were diagnosed. Parents described these complex themes, and I'm just going to brush on the 3 major big themes that the parents described to us during this time. They talked about that their journeys were like riding a roller coaster, and those of us who've been on one, sometimes they're short roller coasters, sometimes long, sometimes high and scary, and sometimes low and easy, and that's how the parents described it. And that navigating treatment options were as diverse as the roller coasters. And they gave us practical tips on how to be present with these parents during that journey. They talked that they wanted health professionals to consider the outcomes that we measure and to harmonise them across all of us, because we all measure different things. But they especially wanted us to actually harmonise our treatment options and be aware of what each other says and does.
Thanks very much, Kylie, for that presentation. You were just on time. How did you find it?
Oh, yeah.
No, really bad.
You not knowing who was out there. That was fun.
Good.
You did a really good job. It must be really difficult, especially with qualitative work, to get all the rich data that you've collected into a 3-minute segment. It feels a bit unfair, doesn't it? So following that presentation, is there anything else you'd like to talk about? Any questions from yourself, Nina, about Kylie's work?
I just loved reading this research. It's real central to what's going on around us at the moment. Obviously, qualitative research is really building pace, and I just think it's really important because it's looking at people's lived experiences rather than sort of the efficacy of the treatment itself, and it really does place children and the families at the centre of the care, and it's looking at what matters to them. And I wonder whether we're asking those questions enough within our clinical practice, and we can sometimes get a little bit bogged down on what those treatment pathways are and how to specifically treat a condition where, you know, there's 2 people in the room, you're the expert, but we really should start to understand, you know, what their preferences are and how they would like it treating, because you know, there's more than one option, isn't there, with how to treat toe walk. I was going to call it toe walk. It's a long word otherwise. So, you know, there's lots of choices, and it's really important that you sit down with, you know, the child and the family and ask them, you know, how would you like us to approach this? And I just love those 3 themes as well about the roller coaster. They could be anywhere along that journey, couldn't they? On that roller coaster, they could be having a high at that point, and they could be having a low. And it really does matter recognising where they are on that roller coaster, because it means that you need to tailor your care differently. And then also just navigating the options. It's really important that you do involve them in that shared decision-making process. It's not an option, it is an ethical imperative, but also it's a legal obligation as well. You should give people choice in their care. And then also that supporting people in the journey. And it's not always that straight path. It's about sort of being clear on what the stages are and talking them through it and supporting them through that process. So I thought it was a really brilliant paper, and I'd love to see more on this subject, but obviously in different areas. I think it's a really important piece of research. So well done, Kylie, and well done for the 3 minutes on the dot. You did brilliant. Professional.
I do try.
Yeah.
So, Kylie, when you consider the research that you've done in the surrounding body of evidence, how would you say that fits with previous research that's been undertaken?
Sorry, say again. No, you go.
Was that for me or for Nina?
Either, whichever.
You want to go, Nina? This paper is actually, and it might be handy, this paper is like a triad. We published 3 papers on idiopathic toe walking within sort of 12 months, and this was like the missing link for me. We published a Cochrane review, which was, for those people who haven't read a Cochrane, it's the highest level of systematic review evidence that is published as much as we can in plain English, and it basically showed that most treatments we use for idiopathic toe walking have very little evidence to support, and that there was really diverse outcomes. And then we also published, and Nina was a co-author, a survey from health professionals, and they gave us over 20 different types of treatments that they used. And so they showed us all of these treatments and they talked about their treatments, and even provided us with statements of, we use these, but we don't really know if they work. And so we heard about the research being pretty useless, health professionals using things that weren't really convinced, they weren't convinced either. And so this was kind of the missing link in the triangle, where no one had ever asked parents before, well, what do you think? Why are we finding this so complex and I guess so challenging? And they told us what they were missing. They told us what was wrong. They were really harmonious in all of them said similar things, that they often felt like they walked in the room and they knew more about it than the person they were seeing, or they had to put pieces of the puzzle together from all the health professionals. And that was really frustrating for them. So I think it's a little bit of this message of, we need to be better, but it's hard to be better when we don't see many children with this sort of condition.
I think it highlights as well that you, as a profession, or perhaps in local teams, we have to have a consistent approach as to how to manage toe walking as well, because if there is that inconsistency, it creates that lack of trust. It's really hard to build that trust and rapport if everybody's saying something different. Obviously, it lengthens the journey as well. And then I think it's also important as well that, obviously what you touched on there, Kylie, is that the people that come to these appointments are the experts as well, and they're the experts in their own condition, and use them and understand their condition as best you can through them as well. And I think that's really important too. So so I think what you kind of can take away from this, and it is that really important bit of that missing triangle, is how do you get your service design together to get it right for this group of people as such. So yeah. Any other questions? Sorry.
Something else we'd like to discuss is how you would take the results of this research and how people at home can apply it to their clinical practice. So things that you would like people to consider in future when treating idiopathic toe walking.
Do you want to have a crack, Nina, or do you want me to?
There's lots of things, and I might not put it in a logical order, really.
It's a Sunday morning, that's forgivable.
It's fine, okay.
Hey, it's Sunday night for me.
I think really what it takes away is that we should really be involving people, them as the experts in their own condition, and hopefully us making sure that our knowledge is where it should be to be able to treat this cohort, because if we haven't got the knowledge, it impacts on their care. So both as in the expert in the room, and we as clinicians, and them as the experts in their own condition, I think it's really important that you start sharing, what's important to them, and you talking through those treatment options with them, being really honest about, there's a lot of uncertainty, And yeah, it doesn't always say that you're going to get great outcomes from any interventions, but then sort of putting that in the context of their life and, well, what would fit with them at that moment in time, and understanding the bigger picture as well, in terms of, these children usually under lots of different services, and that can be frustration in itself. So kind of knowing that you don't necessarily get the best outcomes with toe walking, talking to them about, well, what is a priority for you? Is this a high priority? Knowing that the outcomes of toe walking interventions are not great, what else might you want to concentrate on in the larger picture? I think parents don't always as well. I think we've got to remember as well that sometimes we think that we're making the best decisions by saying, well, this is the best evidence if you do want to tackle toe walking. But sometimes, or quite a lot really, parents don't really want to go down that route. They're happy to leave it and to watch and wait. And I think sometimes this watching and waiting can be undervalued as well. And I think it's important that you do support them with the watch and wait as well, in terms of knowing what your metrics are to say, well, would like to see you again if, so it's like that. If this happens, this is what we need to do. So it might be to do with range of movement, it might be to do with pain or function, etc. And just keeping them involved in that decision-making process so that they feel in control, and it's you going down a path that they actually want to be part of. Because the last thing you want in this cohort is creating lots of appointments and lots of intervention. It makes that roller coaster journey longer than it needs to be. So I just think we just really need to be careful on which roller coaster we put them on in the first place. just leave them sat. That's what I would like people to say. To summarise, we should really properly engage in shared decision making in these cases.
Great. Okay, I think it's time we could move on to questions from the public. So there's been one sent in. Was there anything that really surprised you from the responses, or something that's changed your practice?
Yes, there was a lot. I was surprised sometimes from a number of parents. I heard some treatments and it was more US than Australia based, that were really quite aggressive. And it's not that they were wrong or right, or it was common treatments that I hadn't heard of before. And since that time, I've heard some of those treatments coming into general practice, which surprised me, given some of those treatments, particularly some surgical treatments, have very limited impact on. They lengthen the muscle because they have to, because it's cut and lengthened. But we've got some really good longitudinal papers that show even if you lengthen the muscle, that a lot of children still toe walk after. And what the parents didn't seem to understand was the different outcomes that might be expected with that particular treatment. And it was a real take home for me that they weren't always getting the full story. And when you ask a parent what they want, they may say, well, I really want you to stop my child from toe walking. But the majority of our treatment actually don't work on toe walking. They work on keeping muscles long and strong. And so just because a muscle is longer and stronger doesn't mean that the child will stop toe walking. And so you might have this really physically active and fit child that still toe walks. And so it was about marrying, just as Nina said, the patient expectation with what the outcome of your treatment, what it actually might be. And I guess some of that reinforce some of my practice. I often sit down with parents and write this great big list of, you know what, I only do this really tiny, narrow bit of treatment, but here's all these other treatments that are on option to you from other people. Now, some of these might be more important to you, and I can help facilitate you to get to one of those people who do that, because it's not something I know how to do, or it's not in my scope of practice. But that might be more important to you and your family right now. But let me tell you that if you go down these paths, you mightn't actually get change in toe walking, but you'll get these nice long muscles. And that's really right now the most important thing. You might think it is, but your child can't get their heels to the ground and they hurt. So let's not worry about the toe walking. Let's work on what's not getting the heels to the ground and hurting, because that's what really you're telling me. And it's about unpacking that belief system, the knowledge system, and trying to put them into a big picture rather than going into algorithmic care of the toe walker comes in, this is what I can do, this is the only thing that I will offer them because that's all I know what to do.
Okay.
Lovely. I have a question. So, you looked at people's experiences from the US and from Australia, and you didn't really find any particular differences, did you, in their experiences? But did you find any differences in people's perceptions who had sought out different treatments? So whether somebody opted for surgery or for less invasive measures, did you find any difference in their experiences at all?
So we didn't go down the path of actually drilling down to different treatments. We had some children in our group that had seen up to 7 to 8 health professionals. So everyone from orthopedic surgeons, podiatric surgeons, podiatrists. In America, they call them physiatrists, so a general physician or rehab physician. There had been the use of serial casting, Botox, AFOs, full-length plates, stretches, strengthening. There'd even been some who'd had gastroileal releases and plantar fascial releases. So we had this really broad spectrum of, to me, it was like the Halloween bucket of treats. A child came in and you went, "Pooh, what do you want? Have I got a bucket of goodies for you?" And it really reflected the person who they saw on the day and the skill that that person had, and that's what they were offered. And it really sounded, regardless of the parent, they were the drivers. They were the one at the front of that roller coaster going, "This isn't working for me, I'm going to someone else." And they sometimes were really out of control when things didn't work, or they might have been sent to someone else and they didn't really understand why. Some of them had no idea the difference between some of the health professionals they saw, just that they were all of a sudden, what's the difference between an orthotist and a podiatrist? And why am I at the physio now? I don't quite understand why I've been referred here. Or sometimes in America, you're only allowed to have physiotherapy after surgery. So are they going to use their number of visits before surgery as prehab, or use it afterwards as rehab? And their journeys were just completely messy, and there was no way of unpacking different treatment options because we had them all.
Okay. And just with those that you interviewed, had they kind of come through the other side of treatment and had they corrected themselves, or were they still going through different treatments? And
Yep. So part of the recruitment strategy was a family who had seen more than 2 health professionals and had a child who had idiopathic toe walking. So we had some at the other end, and we had some older kids. We had one in particular who I remember was in a pain clinic because part of her surgery had gone wrong. And we had some really young ones who were actually just starting their journey. They'd seen a paediatrician, had been referred to a physio or a podiatrist. So we had a big, diverse range of young novice experience just starting out, right through to they'd seen a whole lot of people through that journey.
Oh, okay, pretty good.
Lovely. I don't think we've received any more questions on the Facebook page. Have you got like a key takeaway message at all that you'd like to tell people before we end the webinar?
Yes, I would love you to read the paper, simply because the parents left you messages. Our last part of this paper was actually, what would you like to tell health professionals? And there's a bunch of things in the paper, and I will read out one quote because I think it really sums it all up from one of the mums in Australia. And she said you need somebody who is sympathetic and understanding and willing to really work with the individual needs of the child, not a one shoe fits all kind of thing. And to me, that actually summed it all up, that while we can, through lack of knowledge or we're unsure of what our skill is, we can kind of throw what we know. But sometimes parents told us that it was okay to not know stuff and be really open and honest. I don't know, but I know someone who might, and be very willing to pass on that care where it's for the best needs of the child.
Great. Thanks very much, Kylie. That was a brilliant presentation and the questions were good. And thanks, Nina, as well, for joining in and helping out. And as well, Michael, for creating and facilitating, and the public for the questions.
Excellent. There should be a link to the open access paper with the Facebook link for the webinar.